Imagine stepping back into the year 1694.
Okay.
You're in southern Italy, and there's this terrifying invisible killer just sweeping through the population.
With the plague, right?
Exactly, the plague. And you have to remember, there are no microscopes, no lab tests, no real understanding of germ theory at all.
Right, they were completely in the dark.
Yeah. So what do the authorities actually do? They pull out parchment and ink, and they just start drawing a map.
Wow.
They're meticulously plotting every reported case, looking for physical clusters, trying to trace the geographical spread of death itself, just to figure out where to build physical barricades.
It's a really profound image, isn't it?
Yeah, it really is.
I mean, humanity using geography as a weapon against disease long before we even knew what a bacterium was.
Exactly.
And we see the exact same thing happen later in 1854 when John Snow mapped those devastating cholera outbreaks in London.
Oh, right, the Broad Street Pump.
Yes, physically plotting the sick on a city grid to trace the infection back to that single contaminated water pump.
Which is wild. And, well, fast forward to today, March 31st, 2026. As we sit here recording this custom-tailored deep dive just for you listening at home.
It's crazy to think about.
It is. We look back at those chaotic, world-altering days of 2020, and we realize that the modern pandemic response was actually built on the exact same foundation as that 1694 parchment map.
We just swapped the ink for algorithms.
Opting for algorithms. I love that.
Yeah, and that is really the core premise of the material we're exploring today.
Right.
We are breaking down a really comprehensive chapter by Cheryl Joanne Dobson Wainwright, and it's titled The Benefits of Technology in Healthcare Management, Lessons Learned During the COVID-19 Pandemic.
Okay, let's unpack this, because our mission for you today is to extract the absolute aha moments from this incredibly dense research.
And there are a lot of them.
So many.
Right.
We're looking at how a global crisis took a shockingly analog, stubbornly sluggish medical system and just forced it to digitize overnight.
Forced being the key word there.
Right. Because prior to 2020, medical tech adoption was moving at a glacial pace. I mean, we had major U.S. legislation like the ATAC Act of 2009.
Right, and the Affordable Care Act.
Yeah, pouring literally billions of dollars into the system, practically begging hospitals to modernize.
But, throwing money at a systemic issue rarely solves it if the underlying human element isn't addressed.
Yeah, that makes sense.
The hesitation wasn't about a lack of microchips. It was about fear, distrust, a complete lack of operational training.
And massive financial bottlenecks, right?
Exactly. Physicians were incredibly skeptical of new digital platforms that threatened to disrupt their finely tuned, albeit paper-heavy, daily workflows.
Nobody likes changing how they work.
No, they don't. But a novel virus doesn't really care about your workflow preferences. The pandemic acted as an inescapable forcing function.
Yeah, the old way of doing things didn't just become inefficient, it became physically impossible.
Right.
Like, think about traditional manual contact tracing. You have a team of health workers physically calling up everyone an infected person might have breathed on at the grocery store.
Which is fine for a small outbreak.
Yeah, when you have 10 cases, sure, that works. When you have 10 million cases,
Yeah.
the manual system just completely snaps in half.
It breaks down entirely.
So this forced an immediate global pivot to big data and artificial intelligence.
And this is where the historical lineage of those early plague maps really comes into play.
Oh, the GIS stuff.
Yeah, the geographic information systems, the GIS that powered our daily COVID dashboards, they didn't just appear out of nowhere.
Right. The research mentioned they were already doing this before COVID.
Exactly. Public health officials were already using modern mapping tools to track the Zika virus in South America.
But they weren't just plotting sick patients, right?
No, they were tracking environmental drivers, they mapped rainfall patterns, humidity levels, urbanization,
Yeah.
all to predict the exact habitat suitable for the mosquitoes carrying the virus.
So they were mapping the environment to predict the disease itself,
Exactly.
which basically laid the architectural groundwork for tracking COVID-19.
It did.
But with COVID, we fed all this real-time human movement data into AI systems, kind of expecting the machine to act as a crystal ball.
People really wanted it to have all the answers.
Yeah. We tasked AI with predicting disease progression, projecting mortality rates, analyzing millions of lung scans, even hunting for new pharmaceutical compounds.
It was a massive undertaking.
But I have to push back a little on the popular narrative that AI was this flawless, magical savior.
Oh, absolutely.
Because training a neural network isn't like programming a calculator. It's more like teaching a brilliant but highly impressionable child.
That's a great way to put it.
Right. There are bound to be massive blind spots when the data just keeps changing.
What's fascinating here is that the researchers explicitly share that skepticism.
They do?
Yeah, they highlight a massive inherent flaw in artificial intelligence called catastrophic forgetting.
Catastrophic forgetting.
Or the interference phenomenon, as it's known in computer science.
That sounds like a sci-fi horror movie, honestly. Especially when we're talking about systems predicting who lives and dies.
It is pretty unsettling.
How exactly does a supercomputer just, forget?
Well, to understand how it happens, you have to look at how a neural network learns. It doesn't store facts in a neat little filing cabinet.
Right.
It learns by adjusting mathematical weights and biases across these really complex layers of artificial neurons to recognize a pattern.
Okay, I'm following.
Now imagine an AI model is perfectly trained to recognize the specific progression of the original COVID-19 strain.
Yeah.
It has adjusted all its internal math to identify that one specific pattern. But then the virus mutates.
Right, the variants.
Yeah. The Delta variant appears, presenting slightly different symptoms and a completely different progression timeline.
So you just feed the Delta data into the machine so it can learn the new threat, right?
Precisely. But as the algorithm forcefully readjusts its internal weights to master the new Delta pattern, it inadvertently overwrites the math it used to understand the original strain.
Wait, really?
Yes, the new knowledge physically interferes with the old knowledge.
Oh, wow.
So in a...
The problem was, I have a sore throat, I am legally locked inside my apartment, and I need a doctor.
Yeah, the basic human need for care.
And this absolute necessity is what triggered the massive explosion of telehealth.
Because face-to-face interactions were suddenly a biological hazard.
Right.
We had severe social distancing mandates, devastating manpower shortages, and a healthcare workforce that was just physically and emotionally breaking down.
That was awful.
The traditional clinic literally had to be teleported to the smartphone screen.
But, telehealth wasn't a brand new invention either. It was already quietly working miracles globally, often in places where traditional infrastructure was lacking.
Yes, the source mentions some great examples.
Like South Africa. They had been utilizing remote telehealth networks for maternal health support long before the lockdowns.
And in Ghana, too.
Right. In Ghana, they implemented mobile technology specifically to combat the counterfeit drug trade. You could essentially verify the authenticity of a medication via mobile networks before consuming it.
The foundation was definitely there, but the pandemic accelerated the consumer-level diagnostic technology to a mind-bending degree.
It really did.
The capabilities sitting in our pockets right now are astounding. For example, Emory University developed a smartphone application that analyzes images of a patient's fingernail beds to estimate hemoglobin levels.
To detect anemia, right.
Exactly.
Wait, let's break that down because that sounds like magic. How does a phone camera tell me if I'm anemic just from a picture of my fingernail?
It comes down to the precise measurement of spectral coloration.
Okay.
Anemia is characterized by a low red blood cell count, which visibly affects the paleness of the capillary beds right underneath your fingernails.
Oh, I see.
So the app uses image processing algorithms to correct for ambient room lighting, and then it analyzes the specific pixel color density of the nail bed.
Wow.
It correlates that exact shade of pallor to hemoglobin levels, and it achieves a 97% sensitivity.
97%.
Yeah, which essentially rivals the accuracy of an actual point-of-care blood test at a clinic.
That is incredible. And it wasn't just blood levels either. Stanford University trained a deep learning platform to identify skin cancer.
Yes, using convolutional neural networks.
Right, the CNNs, which are designed to process pixel data in images.
Exactly.
It scans a picture of a mole, analyzes the microscopic irregular borders, the color gradients, asymmetries that a human eye might completely miss.
Things we just can't see.
And it compares it against a vast database of over 130,000 known clinical images of melanomas.
The scale of data is huge.
And the result is a smartphone app with diagnostic accuracy comparable to a board-certified dermatologist.
We also saw the development of smartphone tech utilizing the camera and flash to analyze the microfluctuations in blood flow in a fingertip to monitor hypertension.
It's amazing.
And even analyzing subtle facial blood flow changes through the front-facing camera to detect atrial fibrillation.
Okay, so what does this all mean for the traditional doctor's visit?
That's the big question.
Are we just replacing human empathy with a camera lens? I mean, if my phone can diagnose my melanoma, check my hemoglobin, and monitor my heart rhythm while I'm sitting on my couch.
That tension was profoundly felt throughout the medical community.
I bet.
Dr. Natiyama conducted a massive poll published in 2022, gathering detailed responses from 705 healthcare workers spanning multiple countries.
And what did they find?
The findings presented a really surprising contradiction. Despite the technology working and despite the absolute necessity of it, provider satisfaction with telehealth actually decreased during the pandemic compared to how they felt about it beforehand.
Wait, that feels entirely counterintuitive.
I know, right?
The tech finally catches up to the sci-fi dream. It allows them to see patients safely during a crisis.
Yeah.
But the doctors actually liked it less.
They liked it less because they felt fundamentally handicapped.
How so?
Doctors expressed immense frustration over the devaluation of the art of medicine. Diagnosing a patient isn't just about looking at a lab value or a photograph.
Right, it's more holistic.
It involves tactile feedback. You need to palpate an abdomen to check for rebound tenderness. You need to listen to the specific acoustic quality of a lung wheeze through a stethoscope.
Yeah, you can't really do that over Zoom.
Providers felt they were being forced to practice medicine in the dark, relying way too heavily on a patient's subjective description of their pain over a choppy video feed.
That sounds incredibly stressful.
It was. This led to severe anxiety among doctors regarding misdiagnoses and a documented fear that they were overprescribing antibiotics just to be safe, simply because they couldn't perform a conclusive physical exam.
I can completely understand that. A webcam can't feel a swollen lymph node.
Exactly.
But, shifting diagnoses to consumer devices brings up an entirely different hazard.
The privacy issue.
Yes. If you are pushing all of this incredibly intimate medical data, high-resolution photos of your skin, real-time tracking of your heartbeat, your exact GPS location for contact tracing.
Through consumer smartphone networks.
Right. You naturally trigger the next massive crisis identified in the research, which is the erosion of personal privacy and the manipulation of truth.
Data privacy was universally cited as the single greatest concern among researchers evaluating these new technologies.
It's terrifying when you really think about it.
When governments rolled out opt-in contact tracing apps, they faced a literal wall of public distrust.
Because of surveillance capitalism.
Exactly. Citizens were hyper-aware of surveillance capitalism. The fear was palpable. People were asking, if I download this app to help track the virus, am I permanently handing over my most intimate health data and physical movements
to a private tech conglomerate or like a government entity without any real oversight?
Yes.
And that fear wasn't just theoretical paranoia. It severely crippled the public health response.
It really did.
There's a fascinating study by Ramakrishnan and colleagues who evaluated the very first 100 COVID-related apps created globally in May and June of 2020.
Right, looking at accessibility.
Yeah, accessibility and adoption. Only 58 to 59% of those apps could even be downloaded by the general public.
That's a huge barrier.
The rest were locked behind special identification codes, local jurisdictional phone numbers, or exclusive research study codes. So this fragmented rollout just compounded the existing distrust.
And the privacy concerns were technically valid. Standard data protection protocols and historical social norms regarding medical secrecy were effectively waived by global health officials in the desperate rush to deploy these tools.
They just bypassed the rules.
Pretty much. We saw chronic breaches in data privacy, which only poured gasoline on the fire of public distrust at the exact moment when collective unified action was the only way to slow the spread.
And here's where it gets really interesting.
Okay.
Because while people were guarding their data from the government, their social media feeds were being flooded with absolute fiction.
The misinformation.
Yeah. We often hear the term misinformation, but what happened during the pandemic was more like a coordinated signal jamming of global truth.
It was completely overwhelming.
It got so severe that at the 2020 Munich Security Conference, the WHO Director General used the term infodemic.
An infodemic.
Right. It was a deadly barrage of fake cures, conspiracy theories, and fabricated statistics. It's like trying to drink from a fire hose of water, but half the water is poisoned. How does a regular person even filter it?
They can't, really. Yeah. And the infodemic had a staggering physical cost.
Yeah.
Instead of dedicating all their resources to virology and patient care, clinical leaders and researchers had to divert massive amounts of energy into simply battling inaccuracies and political upheaval.
And to combat this, traditional public service announcements on television completely failed.
People weren't watching TV for their news anymore.
Exactly. The WHO actually had to pivot to where the misinformation was breeding. They launched the WHO Alert app directly on WhatsApp and Facebook.
Meeting people where they are.
Right. They had to build automated chatbots capable of answering questions and pushing authentic, verified medical guidance in 15 different languages directly to the phones of billions of users. They literally had to use the infrastructure of social media to fight the disease of social media.
This raises an important question regarding the mechanical trade-offs of modern society.
What do you mean?
Well, the legal frameworks we built over decades to protect individual privacy, like HIPAA in the United States or the GDPR in Europe,
Right, the privacy laws.
they actually acted as massive operational obstacles during the initial panic.
Really?
Yeah, those regulations are intentionally designed to introduce friction, to slow down data sharing to ensure absolute patient consent.
But an exponentially spreading virus does not pause to collect a digital signature.
Exactly. Society had to collectively decide in real time whether we valued our data protection more than our physical safety.
But let's pause there. Let's assume for a second that all those complex ethical questions are perfectly resolved.
Okay, hypothetically.
Let's imagine a scenario where every single person is completely willing to trust a health app, they consent to sharing their data, and the AI isn't hallucinating.
A best-case scenario.
Right. What happens if that willing patient doesn't even have an internet connection?
Yes.
This part of the research completely reframes the entire conversation. We shift from debating the philosophy of digital health to facing the brutal infrastructural reality of the digital divide.
The statistics are a sobering reality check.
They really are.
While we sit here discussing AI and blockchain, we have to acknowledge that out of the global population, roughly 5.25 billion people are active internet users.
Okay.
But that leaves a staggering 2.7 billion people, roughly 34% of the world, with zero internet access.
Over 2.5 billion people.
Yes.
Think about the implications of that. For you listening right now, imagine being told that the only possible way to schedule a life-saving vaccine appointment, or the only way to consult a doctor about your failing lungs.
Or report an exposure.
Yes. The only way to do any of that is through a smartphone portal. But you live in a rural region without a single cell tower.
Or an urban center, but you just can't afford a data plan.
Exactly. How is that public health? How can we call it public health when a third of the public is effectively locked out of the building?
If we connect this to the bigger picture, it becomes painfully clear that sophisticated software is completely useless without equitable hardware infrastructure.
You need the foundation first.
Right. We cannot build a global biological defense mechanism on a digital platform that 1/3 of humanity cannot reach.
It just doesn't work.
Furthermore, even for the 66% of the world who are online, having internet access doesn't mean the medical systems can actually communicate.
Oh, because of the fragmentation.
Exactly. The fragmented nature of competing hospital networks means your data often can't be shared across state lines, let alone international borders.
Right, because the systems literally don't speak the same language.
They don't.
An electronic medical record at a private clinic in Texas is coded completely differently than the database at a public ER in Maine.
It's a huge logistical nightmare.
Which brings us to the unsung heroes of this entire technological revolution. The structural frameworks that force these systems to talk to each other. Specifically, the text dives into HL7 and FHIR.
Yes, the interoperability protocols. To understand why these are vital, think of them as the universal translators of medicine.
Okay, I like that analogy.
HL7, which stands for Health Level 7 International, was developed years ago as a standard messaging protocol for exchanging text-based information between various healthcare programs.
Right.
But as the internet evolved, HL7 became a bit clunky.
A bit outdated.
Exactly. That's where FHIR comes in, Fast Healthcare Interoperability Resources.
FHIR.
Yes, FHIR builds upon the HL7 foundation, but utilizes modern web APIs. It's the exact same underlying architecture that allows your smartphone's weather app to instantly pull data from a distant meteorological server.
Oh, that makes perfect sense.
Right, so FHIR standardizes the data tags, allowing disparate pieces of information like a specific lab result, a patient's identity, and a billing code.
All the stuff that usually gets lost in translation.
Exactly. It allows all of that to be seamlessly linked and understood by any authorized system in the world.
It basically creates a medical Esperanto.
It does.
But, once you have all this interconnected data flowing seamlessly around the globe, you have to protect it from hackers.
Security is paramount.
And that is where blockchain technology enters the healthcare space.
Yes.
We usually associate blockchain with, cryptocurrency bros, but at its core, blockchain is just a decentralized, immutable ledger.
Right, it's just a secure way of storing records.
Exactly. Instead of a hospital keeping all your sensitive health data on one central server that can be easily hacked or held for ransom, the data is secured through cryptographic hashing across a decentralized network of nodes.
So there's no single point of failure.
Right. It means your medical record cannot be quietly altered or deleted by a malicious actor, and every single attempt to access your file is permanently tracked.
It brings accountability.
It essentially builds a trustless system where patient data can be secure without needing to blindly trust a single tech company.
However, all these brilliant tools, predictive AI, FHIR protocols, blockchain security, they require something technology cannot provide on its own.
Which is?
Unprecedented human cooperation.
Ah, the hard part.
Always the hard part. The research concludes by proposing the creation of a massive shared economy managed by oversight organizations.
Like the IPPO mentioned in the text.
Yes, they specifically point to the concept of an Intercontinental Pandemic Preparedness Organization, or IPPO. The ultimate goal is to establish binding, cooperative data sharing agreements between nations and private health sectors before the next crisis hits.
You get ahead of it.
Exactly. Ensuring that the interoperability infrastructure and privacy protocols are fully tested and globally equitable.
So bringing this all together for you listening, what does this deep dive really reveal?
That's the big question.
It shows us that the COVID-19 pandemic wasn't just a biological disaster. It was the ultimate brutal stress test for the global healthcare technology sector.
It pushed everything to the breaking point.
It really did. We discovered exactly what our digital systems were capable of and exactly where the floorboards gave way.
We learned a lot.
We learned the fascinating mechanisms of how a smartphone camera can detect anemia and how an AI can track a virus by analyzing mosquitoes.
Amazing breakthroughs.
But more importantly, we learned that those tools are entirely useless without baseline internet infrastructure, public trust, and a medical workforce that actually feels empowered by the tools rather than replaced by them.
The human element is irreplaceable.
Right. We successfully dragged the analog hospital into the digital age, but the transition left a lot of bruises.
And as we evaluate those bruises, the research makes one thing abundantly clear. In the terrifying fog of a crisis, society is perfectly willing to trade away its data privacy in exchange for physical safety.
We really are.
We will download the tracking apps and share our biometrics if we believe it will keep us alive.
Which leads to a fascinating thought to leave you with today. If we accept that the future of medicine is fundamentally digital, if algorithms become our primary diagnosticians and remote monitoring becomes the standard of care,
it's the direction we're heading.
how does this permanently alter the humans wearing the white coats? If the art of medicine and physical touch are continually replaced by data analysis and blockchain ledgers, will the medical schools of tomorrow stop training physical healers?
That is a profound concern.
You have to wonder, in 20 years, will your doctor be a master of human anatomy or just an elite manager of algorithms?
Something to think about the next time you log in for a telehealth appointment.
And on that note, we're wrapping up this deep dive. Thanks for listening.